welcome to our August Lunch and Learn. So if you don't already have this on your calendar, every second Tuesday of every month, we have this event. So if you're like me, I have it on my calendar. If it's not on my calendar, it's really hard to get there. So just put it on a recurring noon to 1, second Tuesday of every month. And you'll be able to hopefully join us either virtually or in person here at the KMFA studios. A couple of announcements. We have some things coming up. For the first is in October. This is in addition to our Lunch and Learn events. October 26th. So mark your calendars. Of course, we'll send out information about this as well. Will be our annual Top Golf event. So that's a Wednesday evening. I just took my kids to Top Golf. I think because my daughter beat my son, some of us may have had a little more fun than others, but it's always a good event. The second is to mark your calendars for our December forum. So this is, again, the second Tuesday of December, but instead of doing from noon to 1, we extend that out through the evening. So it's several panels. We have a CIO panel. We have a business panel, so a mixture of CEOs and CNOs, and we also have a startup panel this year. And then we roll right into our social event, and that will all be here in this building as well at KMFA. So without further ado, I will introduce our speaker for today, Darrell Woelk. He is the CTO for Green Room Technologies. He's a recognized leader in machine learning, big data, and standards for healthcare interoperability. His business experience enables him to effectively bridge the gap between technologists and business analysts and to implement solutions that draw on multiple scientific and technology disciplines. Today, he's going to be talking to us about how FHIR is spreading through healthcare. So, Darrell, if you will come up, we'll welcome him and thank you for your time today. We look forward to your talk.
Right, thank you for inviting me to talk about my favorite topic, which is FHIR. If you don't know, it's Fast Healthcare Interoperability Resources. And those names, the words were carefully chosen so we could have lots of funny things to say about FHIR. It's pronounced FHIR. I am CTO of Green Room, but most of the discussions I have with medical device manufacturers, software vendors, providers, and payers are not all about technology, they're more about the business, also about the business of FHIR. And so at Green Room Technologies, we talk about business viability. And that's really what I want to talk about today. It's a combination of technology and market awareness and knowing where your product fits in, especially in the world of interoperability. In the world of interoperability, you're not alone, right? You have to operate with someone. And so we focus on market and technology readiness. So I'm hoping today, in the next 45 minutes or so, I'll boost up your technology readiness and market readiness knowledge about FHIR. I'll leave time for questions at the end. And just in case you ask questions about the real business and medical, I have Kristen Norton, our CEO for Green Room, and Bob Teague, our Chief Medical Officer, who can get me out of any trouble I get into with things I've said that don't make any sense. So let me start with kind of the problem, and I think everyone should recognize this problem. So we have, for example, we've got clinic, hospital, and health information exchange, and my patient data is inside of those organizations. And then there's me and my doctor. And between me and my data are a Cerner EHR in this example and an Epic EHR. And nowadays I have a portal, so I can log into the Cerner portal for my clinic, and I could log into the Epic portal for the hospital where I've had surgery. But now I've got two portals. I've got two screens up. I can look at the data, but I don't really have the data. All I can do is see it. Same thing is true with insurance. So let's say right now I have Aetna insurance, but I got a better deal with Cigna. So I'm moving to Cigna next month. Well, now I have to deal with two more portals. And the same thing happens down here, trying to exchange data between clinics and providers. And so that leaves me and my doctor in this situation. That's changing. And what's really forced to change, we started working on the FHIR data standard 10 years ago. We recently had the anniversary of starting the FHIR standard. I started working on this in 2014. So I've got 7 or 8 years into this. But recently, the 21st Century Cures Act requires EHR vendors now to support access to a subset of my data via the HL7 FHIR API. And I'll go into a little bit of detail about what that API is.
Sorry, sir. It's they're not seeing the presentation on the Zoom.
Oh.
I'm going to see if they can see it now. There we go. I think it was that presenter view we were in
Okay.
was preventing it from sharing.
Okay, I apologize to the people online.
I think we're good now. They're giving the thumbs up.
Those are great slides. We'll make those available. Oh, this is still good. Okay, we still got the good stuff. Okay, upper left-hand corner, then the government sort of stepped in 3 or 4 years ago, recognized that APIs are the future, and are now, by the end of the year, all these vendors are going to be required to support the FHIR API. What that means is that now, if I want my data from Cerner and Epic, I can use the FHIR API along with authorization and authentication to get my data. And what it really means is that I can have third-party applications that now, instead of having to use the software provided by Cerner and Epic, I can have a third-party application that either running on a phone or on my desktop. And the same thing with my doctor. My doctor also has access to my data. And I'll talk a little bit about the third-party apps. We have Smart on FHIR and we have CDS hooks. I'll talk about what those are. Those are part of the standard for accessing the data. And then the same thing with the insurance companies, that in the near future, I'll be able to get my explanation of benefits, the information about my insurance from the insurance companies to my third-party apps using FHIR API. It also means that down here, when I change insurance companies, that Epic or that Aetna will send my data to Cigna using FHIR. And that my data can move back and forth between the clinic and the hospital, and that health information exchanges will be able to use FHIR. And then also medical devices. We also have medical devices now that can provide the data with FHIR. One more step then, that was kind of describing in the Central Texas region, we have HASA, which is a health information exchange. You'll hear the word TEFCA mentioned. And TEFCA is a way of sharing FHIR data across the United States. And it's done by taking the diagram I had. We've got 3 different regions that now are what's called QHIMSS and a TEFCA broker. So now we can also move the data across the US through multiple kind of a hierarchical networking. Okay, so I mentioned myself and my doctor. So when my doctor wants to look at my medical records or he wants to have a third-party application, he has a screen something like this. This is eClinicalWorks. On the left-hand side, we have the EHR functions. The doctor could choose what they want to do. At the top is the demographics and history of Darrell. Kind of in the middle here is today's visit. So I'm discussing with my doctor my lipid profile and general examination information. What Smart on FHIR allows us to do is to display data from a third-party application in a small window in the EHR. So the doctor doesn't have to log into something else. It automatically launches, the EHR launches with a button, will launch my Smart on FHIR app. And in this case, you might be looking at prescription reconciliation or something. And there we have, so the data from the EHR is going into a third-party application where we can have innovation. The same kind of thing is for Darrell on my iPhone. So on my phone, I have Sleep Monitor, which is feeding information into the health record, the Apple Health record. But I also now have the health records from FHIR data from Waddell Medical Center. And the way that Apple iPhone got those records was using Smart on FHIR. In this case, it didn't launch out of an EHR, but it was launched from the Apple iPhone. And I gave permission for the Apple iPhone to access my records. And the way I did that, when I click down here at the bottom, add another account, let's say it's Scott and White, my Scott and White login comes up on the screen. The Scott and White login says, Darrell, what kind of data would you like to make available to the health record on the iPhone? And so I in this case, this one gave permission for all of these different types of data. And furthermore, last year we had a rapid standards organization working on getting verified FHIR vaccination reports. So in this case, this is a verified vaccination report that I could take with a QR code and use that at the airport. The airport would scan the QR code, and there would be proof in that, when it scans that, proof that this came from Waddell Medical Center. So that's a big step forward in being able to move my data out of Epic, out of Cerner, put it on my phone, but have verification on that record, so that when the person at the airport scans it, they're able to go to Scott and White and verify that, yes, this is the Scott and White public key that verifies the signature. So that's where the world is going, and that's the business, sort of the business side of FHIR. The way we develop standards, let me spend a couple of minutes going through that. The way we develop the standards, then we start down with the industry organization. So HL7 on the left, that's the organization that I belong to, where we're developing the core standards, creating the base standards. You may recognize some of the other organizations here. Some are specifically healthcare, some are more generic. We work with all of these standard organizations to come up with the basic FHIR core of FHIR. Then we have FHIR accelerator projects, and FHIR accelerator projects are focusing on sort of specific areas. For example, the Argonaut project focused on what is it that the government should require Epic and Cerner to make available. What's the core? What's considered core patient data? And they worked for 3 or 4 years to come up with that, and that's what became the U.S. HIMSS Act. And we also have Da Vinci, which is working on how do providers share data with payers, how do payers share data with providers. We also had a task force that is, if we talk about FHIR across the country, like that diagram I showed you, there are a lot of issues that are not API issues. They're scalable issues. They're how do you find patients? There's been a task force now that's, I think it's turning into an accelerator project. Finally, after 8 years of work, in some cases, the government agencies step in and say, hey, that looks good. And CMS, who handles Medicare, looks at what's been going on. By the time ONC and CMS got involved to come up with the requirements, there were 6 or 7 years of testing that have gone on by all these different organizations who have been testing the APIs. I won't spend much time on this. We'll make the slides available. This is the ONC. And ONC kind of deals at the top with certification, at the bottom with information blocking. On the certification side, the arrows, the red arrows that I showed a while ago, those are the FHIR API capabilities that are required in the Cures Act. And that, at the end of this year, those will become the final rules for that. On the information blocking, this says that a healthcare organization like Scott and White is responsible for making my patient data available to me. So they can't blame it on the EHR. If the EHR doesn't do that, get a different EHR. You're responsible for Darrell being able to put his data on his iPhone. And that definition of what is Darrell's data used to be called US Core. We're now calling it US CDI. And that is a list of patient information that should be available. And what we're doing in the standards committee and with ONC and CMS, defining the next version to add more data to that. And I think we've got version 2 and version 3 now are being discussed. On this, the CMS interoperability side with Medicare, the July 2021, the patient access API that I described became a requirement, and a provider directory API. And also the trusted the TEFCA. And a couple of months ago, that the TEFCA requirements for what does it take to become a QHIN, to be part of that network. All right, so I'll talk in a minute about the FHIR API, but if we look at the FHIR API, it looks complex, but it's modular. So if you talk about FHIR API, you talk in terms of what's the content, what data can I get through that API? Also, what are the functions? So the functions, the CRUD, which is create, update, delete, and then the use case availability, going kind of back into the slide of what are the use cases, provider to provider, payer to provider, clinical research. The current EHR certification, ONC and CMS, is like a little red cube kind of in the corner. This is what the rules require that we support. And that's the US CDI. The function is read-only right now. And then use cases are limited. So what the FHIR accelerators I talked about are doing, they're taking and expanding that little red cube out farther and farther. And I'll talk about the FHIR accelerators and what they're working on in more detail. Okay, so the FHIR accelerator projects I talked about, each of these, I think the Argonaut project was started 5 years ago.
I was in it in 2015.
Yeah, so 7 years. Okay. Yeah, so we've got someone here that has worked on the Argonaut project. As I said, it's sort of working on what data should I be able to see in the EHR, what data should my doctor be able to get out of the EHR. The CARIN project, CARIN, is focused on more me and interactively getting data from my insurance company, and also with something called Blue Button, which has been around for a while, and we're sort of moving that towards FHIR. It's on FHIR now. And then the Vinci project, as I said before, is kind of the insurance companies interacting with providers. And we have 4 other projects that have been started. The Gravity project, we've heard a lot about social determinants of health data. This is data that's not being captured in EHRs today. So there was a number of organizations sort of working on what data should we capture as far as social determinants data. And the Gravity project then is working on how should that data be represented in FHIR. The Codex project, which is focused on cancer data, is focused on what are the representations of cancer data. So as I said before, the FHIR core of FHIR is structurally very nice, but very flexible. So things like the Codex project is focused on what are the SNOMED codes that should be used, what are the ICD-10 codes that should be used for describing various conditions, cancer conditions. The Vulcan project, which is focused on clinical research data. So this is looking at this whole situation now where we have real world data in EHRs, but it's not trusted. And there's a distinction between the data that's gathered in a clinical trial versus the data that's gathered in the normal clinical projects. So they're looking at how do you map between those, how do we bring those two worlds together? And then finally, the Helios project, which is focused on public health. So during the COVID pandemic, it became clear that the way we were gathering public health data was not only technology-wise bad, it was social, sort of the whole bureaucracy involved. So there's a number of government agencies and technology people sort of looking at how do we share data from EHRs with public health data? How do we protect that? So those are the accelerator projects going on now. The other thing we have, remember my diagram with the layers, FHIR Connectathons. And these FHIR Connectathons go on 3 times a year. And in those FHIR Connectathons, we test the implementation of the different fire resources, profiles, implementation guides. The first one was held in September 2013, and there were 30 participants in that one. The most recent one we held May 2022, we had 550 participants. Now, part of that is because we were virtual. And I have a nice diagram with the chart, but it only goes to 2020. But if you see that diagram, it kind of starts out with 30. I think we got up to around 100 when I had to go to Cleveland, and do it in person. The pandemic forced us to go online, which made a lot of sense for testing. So now I can sit in my office or at home sort of and do my testing. And there, of course, the challenge is how do we interact with people? So you lose, it's obviously in the online thing, you kind of lose the interactions. We had 34 testing tracks. So what that means is 34 different implementation guides for fire that are being tested. So we got the core fire standard, and then we've got 34 different ways that we're deploying fire in the industry. And then we held our second CMS Fire Connectathon last month. And it was a combination of testing and educating participants. And we had 1,443 participants. This is all online. And a lot of those were, and there was no registration fee. So that probably explains the difference between 500 and the 1,400. And there we were more focused. We had 14 separate testing and education tracks, really very much built around the requirements that are of insurance companies and providers for their interactions for the CMS with Medicare. Okay, so what is FHIR? So, as I said, Fast Healthcare Interoperability Resources. It is an international standard, and we have international participants in the FHIR working groups that I'm involved with. And it's a set of modular components called resources. And you can think of those, if you understand relational database systems, you can think of those as tables. The idea is that, I'll show you some examples in a minute. And then you can assemble those resources, which are fairly simple, straightforward, into working systems to solve real world problems at a fraction of the price of other types of implementation. And then it's FHIR and is suitable because it's based on REST APIs, a variety of contexts, mobile apps, cloud communications, HER, EHR. I haven't been able to convince either PowerPoint or Word. EHR is actually a word.
I've had that problem.
Yeah, it is. And it shows up in, this is not too bad now, but it shows up when people say, what? Okay, and as I talk a little bit about the technology, FHIR is really a REST API. You can think of it as a REST API accessing resources that could be persistent in a database. And so there are database servers that have been developed that support both for public for testing, but also by very large vendors that are now actually storing FHIR resources in a persistent database. This is kind of a simple example of a diagram that shows how the resources are connected together. So I have a patient at the bottom, and the patient is the subject of the encounter at the left, and a practitioner at the top, and then there were observations and conditions. There were observations about heart rate, and then conditions that have been entered by the physician, in this case, a family history. So that's the way to think of the FHIR resources. This is the actual main page for the FHIR standard. And there are, I think, 120 different resources, but a simple one to talk about the observation resource. If I click on that, it brings up a description. Think of it as a schema in the database sense, a description that not only says here are the attributes for an observation, but if you click on any of the blue, it takes you to a description. So it's very interactive. This is another view of it as UML. And so we have, this is my observation. Let's say it's that observation about heart rate. So there's a subject, and there's a reference to a patient resource as a subject, a reference to the encounter resource, a reference to practitioner resource that sort of builds out that diagram that I was showing. And this is the actual format of the data that comes back. So if you've ever dealt with any other standards, the older HL7 standards, or you can't really understand what it is. So we developed the FHIR standard using the same tools that are used everywhere else, and the JSON format has become the primary format for all the work that's being done on the internet, marketing, other types of industry. And so it's self-describing. So in FHIR, every resource, this example of observation resource, has a unique ID. And this is a pretty simple unique ID, S001. The actual ID is 64 bytes long to allow you to have unlimited number of IDs. And then this describes, in this case, it's glucose. And it says there's a code, and it's self-describing. What there's a code is this 150.15074-8 is a LUNC code, and how would you display that information? And a reference to that practitioner we talked about. Here's the value, the quantity, and interpretation. So if you're a software developer, you can debug FHIR fairly easily by looking and seeing where the problems are. So that makes it much easier for developers to develop FHIR applications. I won't spend much time on this, but I said FHIR is like a database. Well, we also have a query language. So if you're familiar with SQL, FHIR has a query language that is as powerful as SQL to allow you to search for resources. So I can search for all the observations for all my patients of their, say, heart pulse rate. And then you can come up with a very complex query. And what's most interesting and what allows us to really have someone start prototyping right away is those queries I was showing you. This is a browser up on the top window there where the HTTPS://R4. You can type that into a browser and it'll return the JSON data if you're in a public database with no PHI in it. And there are 29 of those for testing. So as a developer, you can start out sort of browsing around FHIR, working in the public databases. Okay, so we talk a minute about the architecture for applications. So when we talked about Epic and Cerner, what they've done is they put a facade, a FHIR facade on top of their existing systems. So when Epic receives this FHIR query that says, give me all the observations for patients that's over a certain age and have certain conditions, they have to take that and translate that into a query against the Epic databases, whatever format they're in. That's on the server side. On the client side, then we have libraries, JavaScript libraries for FHIR. So these are open source libraries. You can include those in your JavaScript program, and those handle all of the REST API calls and all of the authorization authentication required for Smart on FHIR. So those libraries that cover the FHIR REST API, the Smart on FHIR API that includes authentication and authorization, CDS hooks, which is clinical decision support. And I'll talk about that structure in a minute. And then something called FHIR bulk access, data access API, which is a way of getting a lot of data out of the FHIR database and moving it. And this bulk access is being used for moving data between insurance companies and between providers and insurance companies. Okay, and then I'll talk in a minute about Smart on FHIR galleries. Okay, so we have FHIR libraries for just about every programming language that you can think of. It allows you to write programs. And so the real value of this is, in the past, if I was talking to getting data from Epic, I would have a separate API if I was lucky. That was completely different. There's nothing standard about it. So we now standardize that REST API. I mentioned the public test servers, the 29 last count of public test FHIR servers. There are also now commercial FHIR servers. So all the major big tech companies, Google, Microsoft, IBM, have now are supporting marketing products that are FHIR persistence. And what that means is if you're creating a new application, you can store your FHIR data in Google, Microsoft, IBM, or there are just a number of startup companies, small companies that have actually been around for a while, Health Samurai, OneUp Health, Smile, CDR, who their whole business is FHIR persistence. And then I mentioned that health insurance companies are doing the same thing, that putting a facade of FHIR on top of their existing system. And I've got some links in here to the 29 public FHIR test servers. Logica Health is a nice service that's provided. Gives you a personal instance of a FHIR server. So let's say if you're prototyping something for a startup company, you can create an account on Logica Health and have your own private FHIR database that you can test with. And then I sort of listed some links to some of the commercially supported FHIR servers. Mentioned the Argonaut project before, and I mentioned Apple Health Records. I think the Apple Health Records 3 or 4 years ago started accessing the data using FHIR API.
They actually included FHIR in their operating system.
That's right, in the iOS.
Yeah, and so they just basically said, here it comes, and we're on board.
And what's interesting is that I think Microsoft, Apple had sort of been through this health vault thing before, where they thought they would infringe on the healthcare industry with their own kind of here's where you put your health data. And they made a complete commitment, all those major companies 3 or 4 years ago to FHIR. Microsoft, I mentioned, has a FHIR server product, and Google has Cloud Healthcare API. So Microsoft and Google are kind of using FHIR as a way of kind of working their way into the healthcare industry, focusing heavily on FHIR and translating other things into FHIR. Then IBM Watson for Health has a FHIR database. So that's kind of, so here's the FHIR core data, and here's what we're doing with it. The other thing we're doing, though, is the x-axis here is increased data sharing. So we've talked about like my data records, my FHIR records can move, to different insurance companies. I can get them to my third-party apps. But on the y-axis is increased knowledge sharing. So what are we going to do with that data? So just having the data doesn't have better outcomes for patients. So what we're trying to do on the x-axis, improving clinical efficiency, spreading my data out. On the y-axis, though, improving clinical efficacy. So I want to take the knowledge that has been developed and make that accessible. And the way we do that is, let's say, with Smart on FHIR. So if I have an application that does prescription reconciliation or does analysis of cancer data, I can now make that application available to work on data in different places. So I'm increasing knowledge sharing there, CVS hooks, something called CQL, the vaccination health card, and FHIR RDF, which is a representation in OWL of the knowledge, and then finally machine learning. So I've got a couple of slides here that have links for you. This is the main link to the FHIR core standard. Smart on FHIR, so this simple description of Smart on FHIR is a specification that defines a framework for launching FHIR-based APIs from an EHR or from an iPhone. And it leverages OAuth 2 and OpenID for authorization and authentication. And what's important about that is those are the two standards that are used throughout other industries. So all the tools that are used in other industries can be used in the healthcare industry now. And it has not been true in the past. In the past, we've sort of created our own standards for everything, thinking that we knew what was best. Okay, CDS hooks. You can think of CDS hooks as being a smart on fire application that you register with an EHR. So let's say you register with Epic and say, launch my application at specific points in the clinical workflow. If I'm doing reconciliation, launch my Smart on Fire app. If I'm discharging a patient and I want to run an algorithm to see if they're likely to be coming back to the hospital, I can register with Epic or Cerner, launch my app. So there's a registration process for doing that. And the clinical quality language is a higher level domain-specific language that, again, even though I could look at that JSON data and kind of see observations and conditions, what I don't see is what does it mean to have diabetes and have it under control and have tested it properly, at certain times. CQL gives you a way of specifying those kind of things. It's kind of like modules, and is simple enough that a government agency can program, essentially program in CQL. I talked about verifiable vaccinations a while ago. That was based on the Smart Health Card standard. So we're using the W3's verifiable credential standard to prove the authenticity of the data. I mentioned the FHIR bulk data access, FHIR RDF, and finally, so what we've enabled now is I used a data scientist. When I got into the healthcare industry, I thought, well, these healthcare people must have pretty good control. They must have one model, for medical data. It turned out they didn't. And what FHIR gives us is that base level, kind of the base level. But at least it means I can get FHIR data from Epic and Cerner, and I can understand what it means or what it says. And for machine learning, I can then have massive amounts of data that I don't have to do a lot of data cleaning, at least from the format point of view. Okay, here's an example of, so let's say you were to write a Smart on Fire application that accesses something called the Smart on Fire sandbox. I can then put that into the Smart on Fire app gallery. Doesn't cost me anything. I can categorize it. You see these 10, 15 different categorizations of Smart on Fire applications. So here I clicked on care coordination, and I think there are about 20 Smart on Fire apps. Most of these I can click on the view and run those against the sandbox with sandbox data, non-PHI data. So that's kind of the first step if you were writing a Smart on Fire application. But each of the major vendors then has a similar application gallery. But for them, there's constraints on how you get into their gallery. So you still have to go through a testing and certification process, but it's not as difficult as trying to get your application into the deliverable with Epic and Cerner. I listed those galleries. And if you go to those galleries, you can see, you'll see applications that are in the Smart on Fire gallery. And a number, when you look at this gallery, Smart on Fire gallery, you'll see a list of which EHRs they've been certified with. So it becomes a marketing tool, or at least a way of getting your ideas in front of people. Okay, so a couple of other things I want to talk about as we're building on top of FHIR. One of the key capabilities that we need in the healthcare world is care planning. So everything I talked about with observations, conditions, there was always, well, here's what happened. And you can go in there and you can look at all the kinds of things that happen. Care planning really says, well, here's what should be happening. Okay, so there's HL7 has been working for years, kind of on the general model for care planning. So we now have a FHIR care plan resource that follows this structure. And so it allows you to create care plans that can then be exchanged. So if I move to a new physician, or let's say I have a dermatologist and some other physician, they can share. They can see, here's what this physician is doing with Darrell, and combine those or look at least understand what's happening with Darrell. And there's a project called Multiple Chronic Conditions Project in HL7. It's working with a patient that has multiple chronic conditions and care plans by 3 or 4 different physicians. How do we, at least first we're going to make them aware, but then there's the question, well, how do you interact with those? So this is the first step with that care plan. The other area that really FHIR has really rapidly moved into is quality measures. So at the top, an example quality measure would be, let's say I'm a clinic, and the Medicare says that I should have a certain percentage of my patients with diabetes who had their blood sugar tested and controlled. So I have 100 patients with diabetes. What percentage of those patients have the blood sugar tested and controlled? So in the past, before FHIR and CQL, that's kind of what was described. So analysis would say, a good quality organization should have this percentage, 80% or whatever it is. And then they give it to EHR vendors, and the EHR vendors would figure out, okay, I think I know what that means. I'll go get the data here. Okay, what we've done is then with CQL in the middle here, the specifiers now in the red box at the bottom, those are quality agencies, government agency, industry consortiums who are defining here's what quality means. Producers, this is like clinic, and what it's doing, it's calculating what percentage of the patients in that clinic meet these requirements. And then they're reporting that to government agencies, to payers, insurance companies that are going to pay more if you're high quality. And on the left-hand side where it says measure and measure report, those are FHIR resources. So what we've defined is a CQL program, which is easy enough for a government agency expert to understand. They can program in CQL. When they send it to Epic, Epic will analyze the FHIR data with a CQL interpreter. So there's no software being written. There's a CQL interpreter on the left, which is looking at the FHIR data, coming up with yes or no for each patient, and then a standard way of reporting it. And so gradually all of the quality measures coming out of the government now are moving to FHIR. So we've been testing the tools in this for 4 or 5 years now, and we're adding more and more quality measures. So that's an example really where FHIR has solved a number of problems and moved us up on that arrow so that we're sharing this knowledge of specifiers all the way down to the implementation level. And then finally, so quality measure specified as a CQL program executed by a CQL interpreter accessing FHIR data for each patient. So there's no programming involved. There's no systems analyst like me sitting down and coding, in C++ or Java, sort of interpreting, well, here's what I think they meant in terms of the way we store our data. Okay, the final slide I have then is that this is kind of the big picture of how do we get from not just quality measures, but how do we get from evidence-based management to clinical guidelines, which are pushed out in the real world, which are then executable clinical guidelines. Report those back and have a loop of here's what we think the guidelines are, here's what happens when we ran those guidelines with patients, here are the results, here are the outcomes. Kind of filling in this link circle. And so there's a project called Computable Clinical Guidelines. And you can think of this as it's it's that quality measure thing plus here in the lower right-hand corner, the quality measure. But it's also this piece, which is computable clinical guidelines are really about how do you make it happen within the workflow. So I want to specify the computable clinical guidelines, say for cancer, for treating certain types of cancer. I want to turn those into computable guidelines that I can put into clinical decision support, perhaps launched with CDS hooks that says, okay, here's what, if you look at your patient, if you have these conditions, this kind of a situation, we suggest that you use this care plan. We suggest that you do this type of work. And that's where the care plans come in. So it's really taking guidelines, turning them into care plans that are executable, turning those into clinical support, and measuring after you do that, here's what happened. So the upper right says, make it happen. The lower right says, well, did it happen? And then reporting all of that in such a way that you're not just reporting to one government agency or to one insurance company. You're actually rolling all of that data up into public health in some cases or other ways of quality and safety. So that you can return that back up to the computable clinical guidelines again and say, well, did that work? Today we kind of guess, about this. There's no good way of sort of testing if these things work. And so it's all built then on top of FHIR. The reason we can make this work is because we're back down to that basic FHIR core level. Okay, I think that's all I have. Any questions? Yes, Hope.
Okay, so I've got two totally separate questions that I'm dying to ask. I'm going to start with probably the first priority. We are in like one of the most crucial kind of moments for HIMSS and Austin and the state. We're going into the first legislative session that the Texas Senate and House and all the top players are going to do healthcare. So it's already been mandated. We're about to go into this legislative session that healthcare is the priority. We happen to also have a budget surplus. So everybody's going to do an after that. The priority is healthcare. And the big question all the senators, the House representatives, everybody's asking is their concern is this. Some of them think this is already evil because they're so concerned about privacy and data coming out of the pandemic. It's probably the most misunderstood when you're talking to legislatures. They don't understand this at all. So I'm going to ask, my question is, Darrell, who and how, who is the person that we should make sure is working with us on regulatory from our chapter that's going to be with Nora and all of us at the Capitol? Is that you? And second, what's going to be your answer to the attention we get? 15 minutes, right? Introduce yourself, say who we are, and then get them to want to listen and hear about their concerns on privacy and data for the structure to build this in. And Ed Cali is definitely in our things here last month, and our HIEs finally getting funded here in Central Texas. Who on the FHIR camp is that person, and what would you say?
Yeah, that's a good question. And it kind of revolves, like you say, around the privacy. Yeah. It doesn't help any that we have breaches going on.
Yes.
Right? So there are breaches, and then there's the single identity for patients, which is a political thing. I think that I'm not sure I'm the right person, but there are things happening. There are these discussions going on in the technology community and in the government. So it may be a matter of educating Texas on what's happening in the broader, kind of in the broader sense. Now I can talk about the FHIR technology and the sort of the business part, but there's a sort of the government bureaucratic part of it is difficult.
If you were going to answer, we have one in the room right now. And I'm just worried about privacy, for my constituents saying, but we're so committed to healthcare. We're going to put money into it. What could you say briefly about how this would help with that concern? How could you just simply say, this is going to help your concern? What would you say?
Well, I think it really has to be sort of, why are we doing all of this? We're doing all of this to improve the patient outcomes. So unless we can convince them that this is needed, to improve outcomes, I think that's the first step to get over that. And there are some specific things about privacy that we could talk about. And I don't know how that comes across to legislators.
Trust me, we're going to reel you in.
All right.
You're already the choice people here in the board. Darrell.
What did I start with? Do you access your checking account from your smartphone, Mr. State Representative? And is that secure? And we use the same thing. And there's also proven means by which we can de-identify those things that we'd like to graduate from a person to a population. There's provisions for this. And so that's what I'd say.
We can do that another
I also think though that anytime you try to get someone to buy on something in an abstract, that's always hard. So I think it'd be easier, read everything said, pick a use case. If we don't change this in Texas, people die, or the next pandemic's gonna shut down our healthcare system. People will rally around that as opposed to this, like, I don't know, to Darrell's point, I don't know why I'm doing this. And in the abstract, then I'm just gonna push back on privacy and other concerns, but if you flip the script and say, hey, if you don't do this, lives are being your first responders are beyond risk, then you've got something that's actually, grasp and understand why they're doing this.
We can pay too much for healthcare, not the sharing of data, without accessibility. So, starting with the use case. I would make the use case that healthcare is so fragmented and providers are so specialized now that the communication across at the patient level, without this kind of sharing, you have duplicate testing, you have med reconciliation doesn't happen. It is supposed to be the overly important thing, but in all the transitions of care, pieces are falling out. With this kind of possibility, it truly makes it possible for the consumer to say, here are my CBC reports just from last week. I don't think you need to repeat that test. Or if you did repeat it and suddenly my H&H is dropped, well, I'm bleeding something's wrong. So that's the use case I make, is absolutely from the consumer side. The HIMSS can help you as the provider know more about me. And I can transport my records easily. Epic lets you share, once.
It's also interesting that Epic has registered itself with HEFCA and as a quality health information network. And so all of those Epic things that can talk to other Epic things are now set to be able to.
It's really working well. I can manage a lot of people. And it's working really well. And I did want to follow up and ask about TEPTA because I want to know, are people know if the QHIMSS are being formed? I mean, here we are going into the third quarter of the year, and TEPTA is supposed to now be selecting, I believe, the QHIMSS that will participate. Has that?
So
Had they had the buy-in that they expected, or is it been a real ho-hum moment?
Epic has applied. I don't know if Epic has been accepted.
I don't know that acceptances have gone out yet.
That could be.
And so But the odds are very good that it is working because the more viable and have worked out their funding HIEs are all lining up. So for example, Michigan and Indiana are very powerful HINs that have many different providers, organizations hooked up. And so for them to do TEFCA is really just another strength for them. And then from there, they'd be able to talk to each other.
I think what we still talk about really is the commercial world, and I come very much from the government world where we're not on fire yet. We are not on fire. And there's a huge chunk of the population that is not part of the commercial world and is not part of the data sharing that we're talking about. I mean, Texas Medicaid still doesn't participate, you know. If the legislators could be made aware of how much of our population, how much the potential savings is from improved outcomes. I think this is one of the key to the quality that everybody talks about, raise quality and reduce costs, which is kind of an oxymoron, unless you're really sharing information globally.
Good discussion. Any other rolling?
No, sir.
Okay. All right, thank you. Just real quick, I'm Lance Witty. I took over as the VP of Programs coming into this month. So I just wanted to give I know I've been introed before, but I just wanted to thank Darrell. That was just a deep dive that I really appreciate because I've never seen it work together. And I really appreciate the audience for all the questions. A couple of things, it's really great to be back in person, even though we've been doing this in person for a while. My ask of each of you is, share this with somebody else. Share them, we're trying to grow the chapter. We're trying to grow the input that we get, much like in that discussion. I'd really appreciate it if you just share it. Next month, we're going to be talking about cybersecurity. So we got another panel coming up, panel style discussion. And then we'll go into another discussion in October with Nora on priming for that legislative session that Hope kind of brought up. What would we all say to that? And so that will be a great primer for that discussion. As we go into the fall, I think somebody's already mentioned further into the fall, we've got an opening in November, but we've got somebody on the hook to fill that. And then we'll finish up the year in the cool, on the cool patio out here after a long day with our CX panel. One of the tracks that we're really working hard to bring you guys is something more along the AI ML realm. I'm seeing a lot of it in the front end of the business and trying to refine processes and really bring efficiency and reduce fatigue with providers. So there's a lot of cool things out there that we can talk about. If you have ideas for tracks that you would love to see, bring them to me, bring them to any one of the board members. We sit down and talk every month about it.